Good morning to everyone. I'm Saumya Kamalanathan, Allied Health Science, Department of Operation Theatre Anesthesia Technology, and Sri Shanmuga Institute of Medical Science and Research. Today we talk about endotracheal intubation. Endotracheal intubation is a protecting the airway, protecting life. When a patient can't breathe on their own or can't protect the airway, medical terms rely on a tool that simple in appearance but powerful in purpose, the endotracheal tube or ET tube. Think of the airway as a life supporting IV. Normally, air flow freely from mouth to lungs, but trauma, severe illness, anesthesia, or obstructions can stunt that highway down. When seconds matter, clinicals use intubation to reopen it. Introduction is one of the most critical and life-saving skill in anesthesia. ICU and emergency medicine itself maintaining a secure airway, supporting ventilations, and protects the patients from aspiration. Every medical student must understanding why, when, how intubation is performed. What is endotracheal intubation? It is a process of inserting a tube into a trachea through the mouth or nose. The goal is to maintaining an open airway, delivery oxygen, anesthetic gases, or mechanical ventilation. It is a foundation of airway management. First step, open the patient's mouth. Second step, lubricate the device. Third step, insert the device. Fourth step, position the device. Importance of intubations. Why intubation is so important? Prevents airway obstruction, provides complete control of breathing, protect the lungs from aspiration, allow delivery of precious oxygen level, essential during surgery under general anesthesia, save life in trauma, arrest, shock, and respiratory failure. Intubation is the gold standard airway secure method. Airway anatomy. Anatomy needed for intubation: oral cavity, pharynx, epiglottis, vocal cord, trachea, carina. Importance manicures. Snuffing position aligns airway access. BURP manicure improve glottis exposure. BURP means backward, upward, rightward pressures. Indications: airway protection, loss of consciousness, head injury, seizures, risk of vomiting and aspiration, respiratory failure, asthma attack, COPD, ARDS, severe pneumonia, COVID-19 respiratory failure. General anesthesia. All major surgeries helps deliver anesthesia gases, ensure controlled ventilations, emergency situations, cardiac arrest, polytrauma, shock, burns, airway edema risk, critical care or ICU, mechanical ventilation, prolonged unconscious. Types of intubation tubes. Cuffed tube. Cuffed tube is used to adult, prevent leakage and aspiration. Uncuffed is for mostly pediatric patients. Special tubes like a ray tube, it's used for ENT surgeries. Reinforced or armand tube prevents kicking. Double lumen tube, it's used for thoracic surgery. Nozzle ET tube, oral surgeries. Pre-intubations assessment. Pre-assessment before the intubations. Lemon airway assessment. Lemons means L. Look extremely. E. Elevate mouth opening. M. Malambati score. O. Obstructions. N. Neck movement. Malambati classes 1 to 4 classes. 1, 2 is easy intubation. 4 is difficult intubation and 3 is difficult intubation, 4 is no intubation. It's also helped pediatric difficulties. Equipment requirement: laryngoscope, endotracheal tube, size, blade based on age, stillets or bougie for difficult intubation, suction machine, bag valve mask, capnography. Capnography is monitoring of ETCO2, tube holder or tape. Parts of endotracheal tube. Procedure: step by step intubation procedure. First one is preparation, wash and PPE. Check laryngoscope light, select correct tube sizes, pre-oxygenator for 3 to 5 minutes. Patient position, snuffing position, airway access. Laryngoscope. Hold the laryngoscope in left hand, insert the blade, sweep the tank, lift forward. Never pause the teeth, visualize cord. Tube insertion. Insert tube gently between cords, remove the stellate, inflate the cuff. Confirm placement, bilateral airway entry, chest rise, no gastric sounds, capnography waveform. It's a gold standard method. Secure tube, tape or holder, connect to ventilator. And then rapid sequence indication. It's used in emergency cases to prevent aspirations. Fast induction with drugs, succinylcholine choline for muscle relaxation, cricoid pressures, no manual ventilation, high risk example, trauma, poisoning, pregnancy. Difficult airway, signs of difficult airway, obesity, short neck, limit mouth opening, neck mobility, immobility, facial trauma. Device: video laryngoscope, fiber optic laryngoscope, bougie, LMA rescue airway. Never attempt more than 3 failed attempts. Complication of intubation: immediate dental injury, soft tissue trauma, esophageal intubation, hypoxia, laryngospasm. Late sore throat, vocal cord injury, tracheal stenosis, ventilator associated pneumonia. Post intubation care: secure the tube, maintain the cuff pressure, oral suctionation. Check the deep 21 to 23 centimeter adults, reconfirmation positioning after shifting the patients. Real case examples: first case, road accident, vitamin unconscious, intubation done to secure airway. Second case, asthma with secure breathlessness, intubated for ventilation. Case 3, during abdominal surgery, intubation controlled anesthesia. Conclusion: intubation is a core life skill essential for surgery, emergency ICU, trauma, and airway protection. Required good anatomy knowledge, practice, and proper techniques. Safe and effective airway management improves the patient's survival. Thank you.